Hello, I'm Dr. Kristin Walter, Deputy Editor at JAMA. I'm joined today by Dr. Catherine Otto, Professor of Medicine, Division of Cardiology, University of Washington School of Medicine in Seattle, Washington. Today we will be discussing a JAMA review article titled Calcific Aortic Stenosis, which Dr. Otto co-authored with Dr. David Newby and Dr. Graham Hillis. Welcome, Catherine.
Thank you for having me today.
Before we start, I'd just like to mention that throughout this podcast, I will be using the abbreviation AS for aortic stenosis. So to start off, can you describe what calcific AS is?
So the aortic valve, as you know, controls the flow of blood from the pumping chamber of the heart, the left ventricle, into the aorta. And normally it's very thin leaflets that just open widely in systole. With calcific aortic stenosis, there's accumulation of fibrosis and calcium on the valve leaflets, making them stiff so that they won't open fully, sort of like rusty hinges on a door. If that reaches a point that the heart cannot pump enough blood to supply the body with blood flow, the patient becomes symptomatic and treatment is needed.
And how common is calcific AS, and what is the mortality rate associated with untreated calcific AS?
About 1 to 2% of people over age 65 have some degree of aortic stenosis, and that increases with age. It's a little hard to know about mortality. The randomized studies of people who could not undergo surgery, mortality was as high as 50% at 1 to 2 years. And in studies before valve replacement was possible, it was also in that range of 50% mortality at 1 to 2 years.
And what is the mortality rate for patients with symptomatic severe AS who undergo aortic valve replacement?
So with valve replacement, it really restores a normal life expectancy for that patient's age and other comorbidities. Typically, the surgical or interventional mortality is quite low in the 2 to 3% range overall, and people are restored to a normal life expectancy.
And your article mentions two important risk factors for calcific AS, which are aortic sclerosis and bicuspid aortic valve. Let's start with aortic sclerosis. Can you define this condition and describe how common aortic sclerosis is and how often it progresses to AS?
So aortic sclerosis is the echocardiographic finding of just areas of focal thickening and fibrosis on the valve leaflets, little bright areas, which we previously thought were just an incidental finding of aging. But it occurs in about 25% of adults over age 65, and those patients are at risk of progressing to significant stenosis.
The other major risk factor is bicuspid aortic valve. How common are bicuspid aortic valves, and what is the risk of developing calcific AS in patients who have a bicuspid aortic valve?
So a normal aortic valve has 3 leaflets, so a tri-leaflet valve, but about 1 to 2% of the population has a congenital bicuspid valve with only 2 leaflets. And because this valve is subject to abnormal stress and strain, virtually every patient with a bicuspid valve will eventually need valve replacement. Some patients, as a minority, develop valve leakage early in life in their 20s and 30s and need intervention at that point. But most patients develop aortic stenosis later in life, beginning around age 50, but sometimes not into their 70s or 80s, again with calcific changes of the leaflets resulting in a narrowed valve requiring treatment.
And can you discuss some other known risk factors for AS?
So in the cardiovascular health study, we tried to look at, are there treatable risk factors that would prevent development of aortic stenosis? A goal we've not yet achieved, but the factors that are associated are older age, male sex, hypertension, diabetes, hyperlipidemia, and metabolic syndrome. And there's a particular association with lipoprotein a, which has been found both genetically and in clinical studies.
And what about patients with impaired kidney function?
You know, that is part of the spectrum. Certainly people with renal failure are at high risk of calcific valve disease of both aortic and mitral valves, but it's probably not the most common risk factor.
Can you describe the different stages of calcific AS?
We've tried to stage a valve disease similar to how people think of heart failure. So stage A, the earliest stages, are these patients at risk for aortic stenosis or patients with an echo showing aortic valve sclerosis. But once they reach a point where it's actually changing the blood flow across the valve, with a normal blood flow being about 1 meter per second When it gets up to about 2 meters per second, they're actually having impaired leaflet opening. And those patients we call mild aortic stenosis when it's less than 3 meters per second. We call it moderate stenosis when it's between 3 and 4 meters per second, and only severe when it reaches 4 meters per second or higher. And so most patients with mild and moderate AS are asymptomatic, but it is progressive. And once they reach that stage, it will almost inevitably progress to severe valve narrowing.
And can you describe the typical symptoms of calcific AS?
So the symptoms are kind of similar to the heart failure symptoms we have in other conditions, but they typically first have decreased exercise capacity or shortness of breath on exertion, but as it becomes more severe, they can develop angina, heart failure, and syncope or pre-syncope.
And your article discusses how the physical exam is relatively insensitive for the diagnosis of calcific AS, except for those with severe disease, and that echocardiogram is an essential component of the diagnosis. Can you describe the useful information that the echo can provide for the diagnosis of calcific AS?
Echo has become really essential for the diagnosis. On physical exam, a loud murmur, grade 3 or 4 type ejection murmur, or a diminished and delayed carotid upstroke certainly can identify some people. But most patients have a very soft murmur. It may not be that evident, and the findings can be subtle. Whereas the echocardiogram visualizes the valve itself, so it can see, are the leaflets thin and opening normally, or are they calcified with impaired motion? And it can then quantify the degree of narrowing by velocity and by valve area, as well as evaluating how is the heart working, what's the ventricular function, is there hypertrophy, are there other consequences of this disease process.
Great. And can you discuss which patients diagnosed with calcific AS on the echocardiogram should be referred to cardiology?
I think, it's important that these patients see a cardiologist early in the disease process, if possible. I would say if they have any symptoms that might be due to the aortic valve and the echo shows an abnormal valve, all patients with a congenital bicuspid valve, and any patient with a velocity certainly over 3 meters per second should be seeing a cardiologist. The treatment at that point is simply treating conventional risk factors with standard approaches, but it's also monitoring the patient over time. And I think the most important thing with patients is educating them about their condition, giving them information about the expected disease course over time, and making the patient aware of what symptoms are important and should be reported to us promptly, and so that they have that continuity of care so that we don't delay treatment once it is indicated.
And in terms of treatment, your article mentions there are no current medical therapies that slow the progression of AS, but there are certain medical conditions that should be treated to avoid more rapid AS progression. Can you discuss those conditions?
Of course, it would be ideal to have a medication specifically addressing the aortic valve problem, but we don't have one yet, although there are many ongoing studies. So in the meanwhile, it's treating conventional cardiovascular risk factors, hypercholesterolemia, hypertension, diabetes, having patients stop smoking if they are, treating metabolic syndrome. So really trying to have patients as heart healthy as possible. And keep in mind that as these patients are older patients, many of them will have coronary disease as well. So even if we're not affecting the valve disease progression, we will be helping prevent progressive coronary disease in these patients who are likely to need an intervention.
And is there evidence that hypertension worsens or makes the progression to AS faster?
There are studies suggesting that hypertension is a particular risk factor and probably is causal. I think the interesting thing about hypertension is back when I started my training, we were concerned that you shouldn't treat hypertension in aortic stenosis because the patient would not tolerate it. Their blood pressure would drop too much. But in fact, it's just the opposite. Treating hypertension is very important. Of course, you should start with an appropriate low dose and titrate the medications up carefully to maximize the blood pressure response. But patients respond quite well, and it is very important to treat hypertension even when aortic stenosis is present.
And can you discuss the indications for aortic valve replacement?
The primary indication is severe stenosis that has resulted in symptoms. The symptoms of heart failure, angina, syncope, or just decreased exercise tolerance would be the indications for valve replacement. In asymptomatic patients who have severe valve narrowing, we might consider intervention if they're left ventricular ejection fraction is less than 50%, if they're having other cardiac surgery, or if there's evidence of very severe stenosis or rapid progression. But otherwise, asymptomatic patients, we tend to follow for symptoms carefully with echoes every 6 to 12 months and manage their risk factors. There are studies which probably will be reported within the next year or two looking at should we treat asymptomatic severe aortic stenosis, but in the meanwhile, we wait for symptoms.
An aortic valve replacement can be performed with a bioprosthetic valve or a mechanical heart valve. Can you discuss these two valve types, their durability, and specific advantages and disadvantages associated with these different valves?
So mechanical heart valves are made of ceramic material that's very durable, and they last basically forever, but they have the disadvantage that they have to be treated with anticoagulants to prevent valve thrombosis, specifically with warfarin or vitamin K antagonists. So in a young patient with a long longevity, a mechanical valve offers the best longevity, that the valve will work indefinitely as long as anticoagulation is maintained. Bioprosthetic valves have the advantage that it does not require prolonged anticoagulation, usually just low-dose aspirin, but they do degenerate over time. So typically, a bioprosthetic valve implanted surgically will last for 10 years for sure, but start deteriorating, with most needing re-replacement within 20 years.
And what are bioprosthetic heart valves made of?
So most bioprosthetic heart valves are made of animal tissue, like various porcine valves would be the most common, but there's also various other tissues used for those valves. And that's true for both the surgical bioprosthetic valves and the transcatheter valves now utilized in many patients.
And to follow up that question, for prosthetic valves, there are two approaches, the surgical aortic valve replacement and the transcatheter aortic valve implantation. Can you describe the differences in these procedures, the typical length of hospitalization and postoperative recovery with these procedures?
So a surgical valve replacement, which could be done with either the mechanical valve or the bioprosthetic valve, it requires a median sternotomy, so open heart surgery, cardiopulmonary bypass at the time of surgery. And because of that sternotomy, it's a 6-week recovery period of pretty limited activity, unable to drive or lift anything over 10 pounds in weight, and considerable pain, of course, in that recovery and getting back to normal activity. So it is a longer recovery, but it has the advantage that these are valves that we have long-term data on and have been done for many years. The transcatheter valves are put in through a catheter inserted in the femoral artery and advanced to the valve level, similar to just basically a type of cardiac catheterization. So the patient's hospitalization is often just 1 or 2 days. The recovery to normal activity is very rapid, and the amount of pain is considerably less. So as you can imagine, with the differences from a patient immediate outcome point of view, a transcatheter valve is much more appealing to consider.
And based on current guidelines, which patients are recommended to get a surgical aortic valve versus a transcatheter aortic valve?
So the guidelines currently recommend a surgical valve replacement in patients under age 65 years, and that's because many of these patients, a mechanical valve would be the best choice for durability and long-term outcomes. And if a bioprosthetic valve is used in younger patients, again, a surgical valve is likely to have a longer known outcome. The patients over age 80 pretty much recommend a transcatheter valve because the valve durability is going to be adequate for the patient's expected longevity, and the risk is lower with a transcatheter valve compared to surgery in that age range. But we have a large gray area of patients between 65 and 80 years of age who either a surgical valve or a transcatheter valve have had fairly equivalent outcomes from the data we have so far. So in that age group, the decision is based upon many other factors, obviously patient preferences and discussion and other anatomic factors as to which valve would be best in that patient.
An aortic valve replacement decreases mortality, as you mentioned, and relieves symptoms due to AS, but requires long-term management, including lifelong antithrombotic therapy for patients with a mechanical aortic valve and monitoring for valve deterioration and dysfunction. Is there a difference in durability of bioprosthetic valves that are placed either surgically versus transcatheter approach?
The durability of bioprosthetic valves, I think we don't have the answer to whether the surgical and transcatheter are actually different. For surgical valves, we have large numbers of patients having had valves in for 20 years or longer, so we have a lot of data on surgical valves. The transcatheter valves are newer and have been done mostly in patients over age 70 years. So in patients over age 70, I think we've seen fairly equivalent outcomes out to almost 10 years now in terms of durability, but we don't have longer-term durability data. And we really don't have durability data in younger patients, particularly those under age 65. The concern is that even with surgical valves, the durability of a bioprosthetic valve is inversely related to age. That is, younger patients have more rapid degeneration than older patients. So there is concern that a younger patient with a transcatheter valve may not have acceptable durability of that valve, with little data at this point to really guide us in that decision.
And patients with valve replacement are at risk for prosthetic valve endocarditis, which is associated with a mortality rate of more than 20%, compared with less than 5% in patients with native valve endocarditis. Can you discuss guideline recommendations to reduce the risk of prosthetic valve endocarditis?
So the major way to reduce the risk of endocarditis is to have patients optimize their dental hygiene. Most endocarditis originates from oral flora, so patients should see dentists regularly, have routine cleanings, and use optimal techniques for maintaining oral hygiene. We also do recommend in patients with any kind of prosthetic valve that they take antibiotics at the time of dental procedures, including routine cleaning, to reduce the risk of endocarditis.
And after aortic valve replacement, patients may develop complete heart block that requires a permanent pacemaker. How frequently does this occur, and does it happen more commonly with the surgical or the transcatheter valves?
Yeah, I think that is an important consideration, again, particularly as we think about younger patients. Obviously, pacemakers are life-saving devices and fairly easy to put in, pretty routine, but they do have complications, particularly we're appreciating that they can affect the tricuspid valve function over time, and they also do have a risk of infection. So with surgical valve replacement, the risk of needing a permanent pacer is in the 6 to 7% range. So it is not trivial, but it's a fairly low number. And it seems to be higher with the transcatheter valve, probably because the pressure on the conduction system by how the valve is implanted. And the risk is more in the 11 to 15% range of needing a permanent pacemaker.
Before closing, is there anything else you'd like to mention that we haven't previously discussed?
I think it's just important that we all, primary care providers and others, be aware of this condition. It's not something that's so common that everyone's going to see it frequently, but it's also not uncommon, and it is treatable, particularly if treated before the patient has very severe stenosis and adverse effects on the left ventricle. So we want to be aware of it. The hope is that in the future that we might develop better approaches with, for example, handheld echocardiography or artificial intelligence analysis of ECGs or other approaches. And I think that would greatly improve identifying which patients have this condition and how to maximize their outcomes and reduce the risk of adverse effects.
Thank you so much for sharing your thoughts with us about this interesting and important topic. That was Dr. Catherine Otto, and I'm Dr. Kristin Walter. This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.